Hello everyone, it's Dr. Locklear here, and I'm coming to you today to talk about Exemplar 11.A, which is Increased Intracranial Pressure, or IICP, and this begins on page 751 in your Pearson text. So let's get started. We're going to look at the pathophysiology of increased intracranial pressure. How does it occur? What are the causes? What are the risk factors? What are the signs and symptoms that you as a nurse would see exhibited in a patient? What are the diagnostic tests that we use to determine care with the interdisciplinary team? How does ICP affect people across the lifespan at different ages? And then the nursing process, and how do we use the nursing process to work with these particular patients. And these patients can be very critical very fast, and increased intracranial pressure can lead to death, as we talked about in the concept in intracranial regulation. So you need to be moving quickly when you see these changes. So the overview: increased intracranial pressure, or IICP, also called intracranial hypertension, is sustained elevated pressure, 15 millimeters of hemoglobin or higher in adults, in the cranial cavity. An individual's ICP increases and decreases throughout the day depending on the type of activities in which the individual is engaged, such as coughing, bending, sneezing, or straining. These typical brief activities are usually not harmful. Only sustained increased pressure will result in tissue damage. So if the pressure is sustained at longer periods of time, then you may see tissue damage. Cerebral edema is the most frequent cause of sustained increased intracranial pressure, usually from some type of trauma or injury or infection. Other common causes of IICP include hydrocephalus, brain tumors, central nervous system infections, hemorrhage, such as in a stroke, traumatic brain injury, and metabolic encephalopathy, cyst, and status epilepticus. So what is our patho? In adults, the rigid cranial cavity created by the skull is normally filled to capacity with three essentially non-compressible elements. So you have the brain, 85%, CSF, 5%, and blood, 10%. A state of dynamic equilibrium exists. If the volume of any of these components increases, the volume of the others must decrease, and that's that Monroe-Kelly hypothesis that we talked about in the concept. Venous blood, or CSF, will normally shift out of the cranium and into the spinal column in an effort to maintain a near constant ICP. So there's a balance going on there. The normal ICP is 5 to 15 in adults, 3 to 7 in children, and 1.5 to 6 in infants. This is measured intracranially with a pressure transducer while the patient is lying with the head elevated 30 degrees. Blood and CSF both contribute small percentages to normal intracranial volume, but vascular factors account for twice the amount of the increase in ICP that CSF does. The brain requires a constant supply of oxygen and glucose to meet its metabolic needs because the brain is very busy, it's working constantly. 15 to 20% of the resting cardiac output goes to the brain to meet its metabolic needs. Interruption of cerebral blood flow leads to ischemia, which is lack of oxygen and death of the tissue, and disruption of cerebral metabolism. Pressure and chemical autoregulation are compensatory mechanisms in which cerebral arterioles change diameter to maintain cerebral blood flow when ICP increases. In pressure autoregulation, stretch receptors in the small blood vessels of the brain cause the smooth muscle of the arterioles to contract. Increased arterial pressure stimulates these receptors, leading to vasoconstriction. When arterial pressure is low, stimulation of these receptors decreases, causing relaxation and vasodilation. Chemical or metabolic autoregulation works in much the same way as pressure autoregulation. So in this case, the stimulus is a buildup of byproducts of cell metabolism, including lactic acid, which lactic acid can be very detrimental. If it gets too high, your body cannot function. Pyruvic acid, carbonic acid, and carbon dioxide. Carbon dioxide and increased hydrogen ion concentrations are potent cerebral vasodilators that may act locally or systemically to increase cerebral blood flow. On the contrary, a fall in PaCO2 causes cerebral vasoconstriction. Arterial oxygen tension also affects cerebral blood flow, although it is a less powerful mechanism than that exerted by the CO2 and the hydrogen ions. Displacement of some CSF to the spinal subarachnoid space and increased CSF absorption are early compensatory mechanisms of IICP. The low-pressure venous system is also compressed, and cerebral arteries constrict to reduce blood flow. Brain tissue's ability to accommodate change is relatively restricted. The relationship between the volume of the intracranial components and ICP is known as compliance. When the capacity to compensate for IICP is exceeded, intracranial hypertension develops. Autoregulatory mechanisms have a limited ability to maintain cerebral blood flow. When autoregulation fails, cerebrovascular tone is reduced and cerebral blood flow becomes dependent on changes in blood pressure. Autoregulation may be lost either locally or globally because of several factors, including increasing ICP, local or diffuse cerebral tissue ischemia or inflammation, prolonged hypotension, or hypercapnia or hypoxia. So we start to see some of these changes in breathing patterns and O2 saturations and stuff. You really want to think about increased intracranial pressure at this point as well. What is the etiology? IICP may result from head injury, hydrocephalus, which the picture you see on the screen here is a child with hydrocephalus, cerebral edema, excess CSF, brain tumors, abscesses, or intracranial hemorrhage, such as from a stroke. Hydrocephalus results from an imbalance between production and absorption of CSF, which causes too much CFS to accumulate in the brain and the ventricles, and the ventricles will widen. Hydrocephalus may be congenital, so at birth, or acquired as a result of a head trauma, infection, tumor, or other pathogenic processes. Head trauma results from different causes throughout the lifespan, which you may see just different things causing this. Abnormal cellular growth, such as intracranial tumors, whether they're benign or malignant, compete for the space in the cranial area or the cranial vault, and that causes the IICP to increase as well. Increases in CSF production is seen in hydrocephalus or tissue necrosis as the result of a CVA or aneurysms also cause elevations in IICP too. Risk factors. Any factor that increases the patient's risk of trauma increases the risk of cerebral trauma resulting in IICP. Risk factors for cerebral trauma are plentiful, but increase when normal safety conditions such as wearing of protective equipment are ignored. You want to wear a helmet. You see people riding motorcycles, like in South Carolina, they don't require a helmet. Any trauma to the brain will also change the equilibrium of the Monroe-Kelly hypothesis. Other factors that may influence this equilibrium include medications, poor nutrition, illnesses such as meningitis, drug and alcohol abuse. So prevention. The nurse can help prevent IICP by teaching the patient ways to prevent trauma. So we do a lot of education. This includes providing guidance related to the use of PPE or personal protective equipment or other safety measures, wearing seat belts, avoiding phone use while driving. Nurses who work with adolescents and young adults should emphasize avoidance of recreational drug and alcohol use, or no use or limited. For all patients, but especially for older adults, patient teaching related to standard fall precautions is recommended because we know that fall. I apologize for the delay. My battery was running low and I had to stop and plug in my computer. So let me get back to where I was at. It says, in some cases, however, the onset of symptoms may be delayed if the ICP rises steadily because of compensatory measures such as displacement of blood and CFS. If there's been a slow onset of ICP, a decrease in level of consciousness may not be the presenting symptom. Again, if it's a slow onset. Instead, the patient may complain of visual disturbances such as double vision, vomiting, or headache. A patient who presents with these symptoms requires a careful workup, especially a neurological workup. If a lumbar puncture is performed in a patient who has had a slow onset, it could cause fatal brain herniation because the only thing left to displace out of the cranial vault is the brain tissue. If a downward displacement of the brain tissue into the spinal column occurs, the patient may exhibit signs of Cushing triad, irregular breathing, tachycardia, and widening pulse pressure, and we talked about that in the concept recording. Behavior and personality changes occur. The patient may become irritated or irritable and agitated. Memory and judgment are impaired, and changes in speech pattern may be noted. Changes in gait also occur. The patient's level of consciousness eventually decreases. As cerebral hypertension and hypoxia progress, level of consciousness continues to decrease in a predictable pattern to a coma and unresponsiveness, and then usually death. Look on page 753 and you see the etiology: cerebral edema, head trauma, tumors, abscesses, stroke, inflammation, hemorrhage, and then you'll see the clinical manifestations. And I just went over several of those, but please review that chart as well. Collaboration. Treatment of the patient with IICP is directed towards identifying and treating the underlying cause of the disorder and controlling ICP to prevent herniation syndrome. Sustained ICP greater than 40 is a life-threatening emergency, and there is little time to complete lengthy diagnostic tests. The diagnosis must be made based on observation and a neurological assessment. Even subtle changes may be clinically significant. The nurse, who often spends the most time caring for the patient, is most likely to assess those subtle changes in condition and must advocate for the patient's needs. And we definitely need to be in the patient's rooms and observing our patients as much as possible. I've always said you cannot nurse from the desk. Diagnostic test, a CT or MRI, lumbar puncture, but it's not performed when the IICP is suspected because the sudden release of the pressure in the skull may cause cerebral herniation. You want to look at the serum osmolality, ABGs. EEG may be used to monitor depth of coma or diagnose brain death. And then a transcranial Doppler, and this measures cerebral blood flow, especially for patients who have vasospasms related to cerebral hemorrhage. Surgery, here's a couple pictures of shunts. They do surgery, like do a resection of the area that is dead or the infarction, or there's necrotic tissue, or to reduce the brain mass. They also do a shunt to help drain the excess fluid. And then they may do a permanent shunt just to keep the fluid drained at all times. So it may be temporary or permanent. Pharmacological therapy. Medications play an important role in the management of IICP. Diuretics, particularly osmotic diuretics such as mannitol, are commonly used to reduce ICP and are the mainstays of pharmacologic treatment. Osmotic diuretics work by increasing the osmolarity of the blood, thereby drawing water out of the edematous brain tissue and into the vascular system for elimination through the kidneys. But it has to be done at a certain pace. You can't draw it off too quickly because you'll throw the brain into shock. Loop diuretics such as furosemide, the drug of choice, and edequine may be prescribed. Loop diuretics inhibit sodium and chloride reabsorption at the ascending loop of Henle. They cause a reduction in the rate of CSF production, thereby reducing the ICP. Patients with ICP who are prescribed diuretics require close monitoring of electrolyte values, fluid status, and renal function, because if their kidneys aren't working and it can't get this fluid out. Antipyretics such as acetaminophen are used alone or in combination with a hypothermia blanket to treat hyperthermia. Hyperthermia increases the cerebral metabolic rate and exacerbates an existing increase in ICP. Anti-seizure drugs are often required to manage seizure activity, especially if there's been damage to the temporal lobe. Antihypertensives, in particular, such as beta blockers, may be used if the patient's MAP is high, whereas vasopressors may be used if the MAP is low. GI prophylaxis, and we talked about this in the concept recording, H2 receptor antagonists or your proton pump inhibitors often used because patients with IICP are at increased risk for developing stress, gastritis, and ulcers. IV fluids are usually necessary to maintain the patient's fluid and electrolyte balance and vascular volume. Hypotonic IV fluids should be avoided because they can lead to cerebral swelling. If the patient's blood pressure is unstable, vasoactive medications may be administered to maintain the MAP in a range that supports cerebral perfusion while minimizing increases in ICP. When enteral feeding is not possible, TPN may be administered. That's usually through TPN is given IV. Non-pharmacological therapies include monitoring and mechanical ventilation, continuous assessment to determine and respond to changes in the patient's condition, maintaining a quiet environment with limited stimulation will keep the patient's ICP lower. One of the simplest ways to decrease ICP is by raising the head of the bed to a 30-degree angle. And that is important to know. I could see that as the NCLEX question. What intervention would the nurse take with someone with ICP? ICP monitoring. Careful assessment is critical to preserving brain function and preventing secondary brain damage from IICP. Monitoring pressure with ICP monitors, measuring cerebral perfusion pressure, and measuring the oxygen levels of brain tissue can provide useful information in guiding the care of patients with IICP. Cerebral perfusion pressure, or CPP, or the difference between MAP and ICP, can be readily calculated, allowing more precise manipulation of therapeutic measures to maintain cerebral perfusion and thereby preventing that ischemia. We want that area to be oxygenated. The CPP should ideally be maintained between 50 and 100 in adults. When a patient's CPP falls below 50, compensatory measures within the brain might not occur and cerebral blood flow will decrease as CPP continues to decrease. The criteria for ICP monitoring depends on the patient's condition, but in general, patients whose condition is salvageable, who present with an abnormal CT scan and have a Glasgow Coma scale of 8 or lower should be monitored. ICP is also monitoring is recommended for patients with a normal CT scan if 2 or more of the following factors are present. Unilateral or bilateral motor posturing, and we talked about posturing in the concept. Systolic blood pressure less than 90, age greater than 40. Basic monitoring systems include an epidural probe, a subarachnoid boulder screw, and an intraventricular catheter. And these are listed on page 755, and you can read about the intraventricular ICP catheter on page 755. I'm trying to keep this not too lengthy for you. It also talks about the microtransducer, the transcranial blood flow, and another device is the Lycox system. So make sure that you read about these monitoring systems on page 755. Mechanical ventilation. Patients with IICP often require intubation and are placed on a ventilator for airway protection and respiratory management. Mechanical ventilation may be used to maintain partial pressure of oxygen and carbon dioxide, preventing hypoxemia and hypercapnia, both of which can increase the ICP. Maintaining adequate oxygenation with a partial pressure of arterial oxygen of about 100 and a partial pressure of arterial carbon dioxide of about 35 is important. The patient with IICP and signs of impending herniation may be judiciously hyperventilated to cause cerebral vasoconstriction. However, this option also increases cerebral ischemia, so it should only be used until another means to decrease ICP can be instituted. And we talked about that in the concept video as well. Mechanical ventilation, you can get more detail on the exemplar of acute respiratory distress when you talk about the oxygenation chapter. Other therapies, physical therapy to prevent muscle atrophy for patients who are unconscious or bedridden more than a few days. Nurses must be diligent to prevent the formation of decubitus, or we don't really say decubitus anymore. We actually call them pressure ulcers or pressure injuries. Now is the new terminology, pressure injuries. But cautions with their movement and stimulation of the patient so as not to further increase ICP. Occupational therapy helps the patient regain motor skills for activities of daily living. Respiratory therapy for patients that require mechanical ventilation during and after being weaned. Speech therapy may be needed to help them learn how to talk again for those areas that are damaged in the brain. Children, infants born more than 10 weeks prematurely can sustain intraventricular hemorrhage. The earlier the delivery and the smaller the newborn, the higher risk of IVH. All infants born at gestational age earlier than 30 weeks should have a cranial ultrasound to assess for the presence of IVH. The blood vessels in the brains of premature infants are not fully yet developed, and this may be a factor in development of IVH. If an infant experiences only minimal bleeding, then there may be no permanent damage. Greater amounts of bleeding may put direct pressure on the brain and cause permanent damage. Manifestations of IVH in the newborn range from no visible signs or symptoms to decreased muscle tone, labile vital signs, and periods of apnea, lethargy, or seizure activity. Newborns with IVH may develop IICP, which may be relieved by performing a lumbar puncture or inserting a shunt. Newborns with IICP require special handling to reduce further damage and should be cared for in the NICU. The unique anatomy of the skull in infants allows the symptoms of IICP to present differently than in children or adults. Because the bones in the skull are not fused, an infant with IICP may have bulging fontanelles, separated sutures on the skull, drowsiness, or vomiting. In children, and as ICP increases in infants, the signs and symptoms of ICP present similar to adults. Examination may reveal headaches, weakness, eye movement, disturbances, behavioral changes, decreased level of consciousness, or seizures. Infants and young children may experience IICP as a result of falling, abuse, bumping their heads. Preschool and school-age children risk for like bicycle accidents, swimming accidents, and activity-related accidents such as sports. Adolescents, motor vehicle accidents, car crashes, addiction behaviors, and trauma resulting from violence. Pregnant women, the physiologic status of pregnancy does not directly affect ICP. However, a condition called idiopathic intracranial hypertension exists and is common in obese women of childbearing age. If the patient with IIH becomes pregnant, neurology and obstetrics should work together closely to ensure safety for both mother and fetus. Medications to treat IIH can usually be taken throughout pregnancy, and patients can usually have a normal vaginal delivery. However, the safety protocols for some medications used to treat IIH are not known for all gestational ages, so medications should be taken only after discussing the risks and benefits with your physician. For these women, pregnancy-related weight gain should be on the lower end, 5 to 9 kilograms. If there are optic nerve dysfunctions, the second stage of labor should not be prolonged, but otherwise no special care should be provided to pregnant women unless they have, underlying situations. Older adults are prone to falls. As stated earlier, older adults may take medications that increase their risk for falls. Sensory losses and instabilities can increase the risk for accidents. Increased blood pressure associated with hypertension may damage blood vessels, especially ones in the brain, and cause them to be more fragile, increasing the risk for hemorrhage, stroke, and related IICP. Undiagnosed or poorly controlled cardiac arrhythmias may cause a decrease in cerebral blood flow, which can lead to vertigo and falls. Often, arrhythmias originating in the atria are treated with medications that interfere with the clotting process, which can turn an otherwise simple fall into a catastrophic hemorrhage. In addition, brain tissue volume decreases with age. As a result, there is more room in the cranial vault. A hemorrhage may have room to expand over a longer period before symptoms are noticed, and these symptoms may be more subtle than those from a hemorrhage that causes an abrupt increase in ICP, and it may be too late by the time you see these symptoms. In older adults, the empty space in the cranial vault may also become passively filled with CSF. Normal pressure, hydrocephalus, causes enlarged ventricles without a dramatic increase in ICP because the patient has had time to adjust or compensate to the CSF. The Haken triad of dementia, gait apraxia, and incontinence are classic signs of NPH, which rarely occurs in patients under 60 years old. NPH is often treated with medications that decrease CSF secretion, but it may ultimately require a shunting procedure, as only 25% of patients can be treated with medications. So the nursing process. Proper assessment of the patient is vital. Not only should assessment involve neurologic tests, and it's a detailed neuro assessment, but it should also help identify the underlying cause of IICP to provide insights into the best treatment. Observation, patient interview, and physical assessment are all key components of the nursing process. However, keep in mind that some patients, especially those with decreased level of consciousness, will be unable to complete a patient interview, so the nurse will need to rely on just observation and physical assessment of the patient. So observation and patient interview. Observation of the patient, noting the patient's level of consciousness, noting the Glasgow Coma Scale score. Observation looks at motor control. Ask the patient or caregiver about the patient's primary complaints. Ask about vision, nausea, vomiting, headache, breathing problems, behavior issues, and events that led up to it. The physical exam. From an alert patient presenting at the clinic, urgent care center, or emergency department after a fall or trauma, follow the assessment guidelines. Assessment includes level of consciousness, behavior, motor, sensory functions, looking at the pupils, reaction to light, their vital signs, their temperature. An elevated temperature would increase oxygen consumption, further increases ICP, because the higher temperature goes up, the more we breathe. Pressure on the brainstem may compromise the function of the cranial nerves. Ongoing monitoring. We want to monitor every 15 minutes up to an hour. Patients with unstable ICP need frequent monitoring. You want to look for trends because the vital signs alone do not correlate well with early deterioration. Sudden changes in neurologic signs often indicate deterioration. Monitor the pulse oximetry. You want to keep the O2 sats and the CO2 levels within normal range. Safety alert, often the earliest manifestation of a change in ICP are alterations in level of consciousness and respirations. So it's important to assess that patient and report those changes immediately to the physician. Here are your nursing diagnoses, your planning, how you want the patient, the patient will have a ICP less than 20. They'll have adequate cerebral perfusion, and they won't experience any adverse side effects. Implementation, ensure adequate oxygenation, give them some oxygen, reduce intracranial pressure, reduce environmental stimuli, reduce the risk of infection, PPE, hand washing, and education for the family. And just read through this on page 757 and 758. And it talks about ensuring adequate oxygenation, talks about suctioning, providing oxygen, ways to reduce intracranial pressures. Again, elevate the head of the bed to 30 degrees. That's very important. Avoid the prone position. Safety alert. If neck trauma is involved, the bed may be kept flat until x-rays of the cervical spine show no fracture. So we need to make sure you don't have any fractures. Also on page 757, it talks about the Crede method, the method of applying pressure to the suprapubic region with the fingers of one or both hands to empty the bladder. But it's not always effective. And then ways to reduce infection and environmental stimuli. You have a patient teaching on page 758, and it said patients who have or at risk for IICP. I would read over that. And then our evaluation. Where do we want the patient to be? Of course, we want them to return to a normal state. Thank you.